Respiratory disorders. So this slide here is just a good reminder of locations for auscultation. I threw this one in here to illustrate to you when they do an x-ray, if they do something called an AP and lateral. AP is anterior, posterior, and then lateral. This is what you'd be looking at in the lung field. So when you're looking at your x-rays, just keep that in mind. And of course, this is just a fun little cartoon because almost everybody feels like they're dying when they have a head cold. It just kind of feels that way. Viral upper respiratory infections, these are also known as the common cold. They're going to be the most common type of respiratory infection. They're highly contagious with a peak incidence in September running through to late July or even late April. And the prevalence is higher going to be in school and work environments. Think about people that are close together in close proximity. So rhinoviruses are going to be the most common cause with over 100 different strands of that have been identified. They can also be caused by other viruses like syncytial viruses. That's going to be your RSV, coronaviruses, of course, and adenoviruses, and they're spread through sneezing, coughing, and direct contact. So think about your droplets, your droplet precautions. These viruses usually spread when the hands and the fingers pick it up from contaminated surfaces and carry it to the eyes and the mucous membranes of the host, and that's going to be us. So infected individuals are going to shed the virus for a few days prior to and after the appearance of symptoms. That's when you're going to be contagious. And these can last for a few days up to 2 weeks. So these are some of the manifestations. You're going to have congestion and discharge, so nasal discharge, and that's pronounced coryza. Sneezing, coughing, sore throat, low-grade fever, headache, malaise, and muscle aches. So low-grade fever, we have to remember that, there is a normal for temperature, but everybody's baseline is just a little bit different. So it could be as low as 99, and it could be just a little bit lower than that. Just depends on the patient. But mostly you're going to be looking from like 99 to like 100. Your treatment for this is going to be based on your symptoms, so you're going to be treating the symptoms. Generally, this is going to be mild and self-limiting, but sometimes complications do occur, such as sinusitis, which we'll be talking about later, or otis media, which is an ear infection. You're going to encourage rest and fluids. The fluids will really help to loosen secretions. That way they're not as thick, and that way the patient can immobilize them. You're going to, with decongestants, you want to be cautious with those, especially with cardiac patients, because they stimulate the sympathetic nervous system. That's going to increase your heart rate and your blood pressure, as well as peripheral vascular resistance. So you want to be very cautious in telling people to take decongestants. There are some available out there. I don't expect you to know them, but there are some available out there, like chloracetine, which is a little bit safer to take with people that have hypertension. Antihistamines, of course. Gargling with salt water tends to help too. The other thing is people tend to be a fan of nasal sprays. You want to advise patients to only use nasal spray decongestants in the short term, because they can lead to rebound congestion and dependence. So you don't want to use those for longer than 3 to 5 days. Plus, they really affect blood pressure as well. You want to maintain good health and stress-reducing activities that support the immune system, and that can help prevent upper respiratory infections. Educate your patients regarding, getting ahead of myself here, sorry about that. So, getting back on topic with this, so gargling with salt water does help to reduce any type of symptoms, helps with symptom relief like the sore throat, as do lozenges and analgesics. So with analgesics, you want to use mild ones like over-the-counter ibuprofen if they can tolerate it, Tylenol if they can tolerate that. So here's where we get into education. So like I said before, you want to educate your patient on proper hygiene, covering their mouth when they sneeze, disposing, and you want to cough into your elbow. This is something that we commonly know, but not everybody knows that. So if they do use a tissue, they want to dispose of that tissue right away, and then they want to wash their hands. Stay home when they're sick. A lot of times people try to tough it out, but really that's just going to spread it to other people. And now more than ever, people should really be aware of health promotion and hygiene. And along with your education here, you want to include education on these items over here on your treatment, because these patients aren't going to be admitted. They're going to be going home. So if they do come into prompt care or something like that, they're going to be discharged with just advice on how to manage symptoms. So influenza is highly contagious viral respiratory disease, and really every year we come out with flu vaccines for this, and it's going to be targeted at the most prevalent one. So this tends to be mild and self-limited, but it can be more serious in elderly and individuals with chronic heart failure, lung conditions, people that are immunosuppressed. And every year there's about 65 million cases of this. So it is quite prevalent. 90% of deaths of influenza are going to be from patients 65 years of age and older. So really, if you go back studies on this, if you go back and look at some of the studies, and they go back as far as 1976, the flu-related deaths range from a low of about a little less than 5,000 to as high as 56,000. So the average of this is going to be about 25,000, so it can be quite serious. And you just want to make sure that you're following your hospital guidelines with these. Most of the time when they come out, they're epidemics and pandemics, and they spread quickly. So I'm not going to go over the difference with you between a pandemic and an epidemic, because really at this point with what's going on, you should really know this. This is probably beating a dead horse, so to speak. So just know that there is a difference between the two, and if you have questions, I'd be happy to explain it to you, but you've probably heard it already. So transmission for influenza is going to be by droplet and direct contact again. There's going to be 3 major strains of the influenza virus. That's going to be influenza A, influenza B, and influenza C. Influenza A is responsible for most infections and for the most severe outbreaks of the flu due to its ability to really alter surface antigens and bypass previously developed immune defenses. So that one's going to be your culprit for a lot of it. A causes infection in birds, pigs, whales, and humans, of course, and there's been several pandemics for this that we've seen through time, and it's killed quite a bit of people. And this is what we test for in the hospital with a swab up the nose. It doesn't go as far back as the influenza swab, but it's a similar type of process. So influenza B in humans, same response as influenza A, but it doesn't really create pandemics like we see with A. And then C is going to be in humans, pigs, and dogs, and that causes mild respiratory infections, and almost all adults have been infected with it, but there's not really a vaccine for it. This has a relatively short incubation period, so we're looking at 18 to 72 hours before the patient comes down with some symptoms. So this is a good chart on how to determine if it's a cold or a fever, or cold or the flu. And really there's a lot of debate and conversations about this, but there are some significant differences. So with flu, you're going to have rapid onset, and there's going to be profound malaise that can develop very quickly with an abrupt onset of chills. So patient, if you've ever had this before, you know that all of a sudden you just didn't feel good. It just kind of comes on quickly. So chills, fever, malaise, muscle aches, and headache, typically dry, non-productive cough, sore throat, substernal burning, and coryza. Again, that's your stuffy nose, your runny nose. Symptoms last for 2 to 3 days for up to a week, and sometimes a little bit longer depending on the patient. Cough, fatigue, and weakness can last up to several weeks. So even though you're starting to feel a little bit better, some of that is going to be ongoing. So increased risk for secondary bacterial infections with these patients, such as sinusitis, otitis media, bronchitis, and pneumonia. These can cause COPD exacerbations too. So remember this when we get into COPD, that one of the things we want to do is prevent illness, and this is going to be one of them. Other complications are going to be an inflammation of skeletal muscles, myocarditis, encephalitis, and GB. So that's Guillain-Barré. They can also cause a rare or potential complication known as Reye syndrome, and that develops within 2 to 3 weeks after the onset of influenza B. It has about a 30% mortality rate, and it causes rapid hepatic failure, encephalopathy, and swelling of the brain. So that mostly occurs in children, so not so much so in adults. Treatment for this, we really want to focus on prevention. So we want to protect vulnerable populations, and those are going to be your primary focus in relation to influenza. So healthcare professionals, we are required to get vaccinated for influenza yearly. It used to be it was optional for us, and then you had to have a waiver, and now it's really mandatory. And that is really to protect the vulnerable population. So if you remember what I said about the deaths and the incidences of death, most of those patients are going to be over the age of 65, and the ones with health complications, and that's our population that we're caring for. And that new vaccine, that is created yearly, and that's using an antigen of the flu strain that's predicted to be the most prevalent. So there's a lot of research that goes into that. They can't have the vaccine, so there's some contraindications to having the vaccine, and they're on the checklist that you would go over with your patient prior to receiving that, and that's if they've ever had a previous anaphylactic reaction to the vaccine. It has to be a true one, not just a side effect, but a reaction. Other contraindications are going to be an allergy to eggs or previous history of Guillain-Barré. We don't want those patients to receive the vaccine because it increases the chance of recurrence. And really, education is big with this, because a lot of people will tell you that they've had reactions to the vaccine, and really reactions are rare. Mostly what they're going to end up having is maybe a low-grade fever, some malaise, and myalgia. So that's going to be a lot less severe than if they actually came down with influenza itself. A couple different medications are listed here. This is going to be if your patient has been exposed. So you're not going to give the Flumidide unless your patient has been exposed. So this is going to be used as a prophylaxis in unvaccinated patients who have been exposed to the virus. The med should be administered within about 48 hours of exposure if possible, and unvaccinated persons should really receive the vaccine along with the antiviral. Antitussives, they might give them some guaifenesin with some, a mucolytic and some analgesics, again, mild. And then no antibiotics. This is not something that can be treated with antibiotics. So a lot of people like those antibiotics and they hang on to them, but it's really not a good idea in this case. Education, you want to educate them on prevention. So hand hygiene is going to be huge. You want them to wash for 20 seconds. There's a lot of different things that they can sing happy birthday. There's a lot of different techniques for this. Cough etiquette, so cough into a tissue, elbow, shoulder. Avoid touching your eyes, nose, and mouth, and avoid contact with sick people. Keep sick children at home. Isolate them. If you are sick, don't go to work. You must rest and stay home until you're about 24 hours fever-free without medication, and that applies to hospital workers as well. So if you have a fever, you have to be fever-free for 24 hours before coming to work, and that's with no Tylenol, no ibuprofen. So exposure, of course, we're reducing exposure, stress reduction, and health promotion. So what if you are taking care of these patients in the hospital? This patient should really be placed on droplet precautions, and that's droplet isolation. So you're going to wear a surgical mask when you're entering the room. Eye protection is required if they're coughing, so that can be done with goggles or a face shield. Hand hygiene, of course. A patient wears a mask when leaving the room, and you're going to limit leaving the room to only medically necessary purposes, so if they need to leave for a test or a scan. And notify anyone that's receiving the patient. So if they're going down for an x-ray, MRI, whatever they're leaving the room for, you need to notify that department so they can take necessary precautions. You must wear a mask during flu season if you choose not to get the vaccine. That was prior to when it was considered mandatory. So now we all have to receive it unless you have an allergy or anaphylactic reaction, and then you'd be wearing a mask. So your nursing diagnosis for influenza, ineffective breathing pattern, that is really going to be due to activities. You want to promote periods of rest, elevate the head of the bed to promote drainage of nasal secretions, and that's going to also improve lung expansion. Ineffective airway clearance, so monitor the effectiveness of the cough, give adequate hydration to help loosen those secretions, and increase humidity of inspired air. This is not something the humidity is not something we can really do in a hospital. We can't put a humidifier in there, but if they're on oxygen, you can add humidification to it. Sleep pattern, they're going to have a hard time sleeping if they're not feeling good, so antipyretics to manage fever, analgesics for pain before bedtime, that will help them to sleep. Risk for infection, use standard precautions of care, so all staff and visitors must wash and maintain a distance of 3 feet from the patient, wear a mask when you're coughing or sneezing, and droplet precautions. So patient should have a private room, caregiver's mask, and patient masks when being transported. You're going to hear me say that a lot during this lecture for patients that have infection. Sinusitis is going to be an inflammation of the mucous membranes and the sinus cavities, and this usually follows an upper respiratory infection. So our common pathogens are here as pneumonia, influenza, and staphylococci. And this occurs when the mucous membranes swell or become obstructed, and that really impairs drainage. The mucus secretions are then collected in the sinus cavity, and that creates an environment for bacterial growth. Other causes for this can be nasal polyps, a deviated septum, rhinitis, tooth abscess, or swimming. That can cause it too. And in hospital patients, this can occur with prolonged NG intubation, nasotracheal intubation. So manifestations of this, they're going to have a lot of congestion with coryza. Again, that's your discharge. Pain and tenderness, and that's going to be with palpation if you palpate over the sinus cavity. Halitosis, that's your bad breath. They could have a fever, headache, and malaise. And this pain that they have, it can also occur when they're leaning forward, and it may refer to the upper teeth, so they might feel like it's there. The symptoms worsen for about 3 to 4 hours after waking and become less severe in the afternoon, and that's due to drainage of mucus. And nausea and vomiting can occur too from this. So if they've got postnasal drip and lots of discharge, that can be an irritant to the stomach. Antibiotics will be ordered if symptoms last more than 7 days, so they're not going to be ordering those right away. Nasal spray can be used to help relieve some of the symptoms, but again, you don't want your patients to be using those longer than 3 to 5 days. Antihistamines will decrease nasal congestion and promote sinus drainage. And decongestants are used to reduce mucosal edema and promote sinus drainage. So again, with these, and I won't burden you by saying it over and over again with these precautions, but use caution with these medications with people with hypertension that are in heart failure and so on. Mucolytic agents, those are going to be like your guaifenesin, and that's going to help liquefy or thin secretions and promote drainage. For patients with chronic sinusitis that doesn't respond to medications, they may also require surgery, so just keep that in mind. You're going to administer any analgesics, apply ice packs to the nose, elevate the head of the bed, and that's going to assist with drainage. Some of the other things, they might try topical steroids, although that doesn't happen very often. A neti pot, that's something that people with chronic sinusitis will have at home, and they will use. We don't often use those in the hospital. Usually respiratory will come up and do a nasal lavage on them, and then aromatherapy. Education, you're going to increase fluids. This really helps to thin secretions, educate them on their nasal spray again, help promote postural drainage, follow their treatment, and then proper hygiene. So this is going to be pharyngitis over here and tonsillitis on this side. So pharyngitis is typically viral, and it may be caused by one of the variety of bacteria. And bacterial pharyngitis is typically caused by group A strep, so it's going to be strep throat. For both pharyngitis and tonsillitis, they're contagious and they spread by droplet, and they have an incubation period for a few hours to several days. So that depends on the causative organism. So depending on what it is, it may develop rather quickly. Symptoms usually resolve about 3 to 5 days after onset, and viral tonsillitis may occur in epidemics such as people living in crowded conditions. So there's a lot of overlap here with pharyngitis versus tonsillitis, but with pharyngitis you're going to have pain and fever, a sore throat, headache, malaise, neuralgias, and myalgias. You're going to have lymph node enlargement possibly, and then with tonsillitis it's going to be a little bit different. So with tonsillitis you're going to have fever, malaise, sore throat, pain, and difficulty swallowing. The pharyngitis, again, that's the one here on the left. You may have some anterior lymph node involvement, and they're going to be enlarged and swollen. With the tonsillitis, the tonsils right here and right there, they're going to appear bright red and edematous. White exudate might be present on the tonsil, and pressing on it is going to produce some purulent drainage. So if you're pushing on this while you're looking, you might see that come out. The uvula might be red and swollen, and the tonsillar lymph nodes are usually tender and enlarged. These can really lead to complications such as abscess, scarlet fever, toxic shock syndrome, rheumatic fever, and more. So there's quite a few things that can happen from this. Your treatment's really going to be the same with both of these, with the exception of the tonsillectomy. So they're going to be aiming at symptom control, antipyretics for fever, analgesics for pain, antibiotics if necessary. So symptom control and reduce complications. And with the ones that are severe, a tonsillectomy. And pray that your patient does not have to have this as an adult, because this surgery is quite painful on an adult. It's much easier to do that when they're a child. Sleep apnea, that's going to be characterized by frequent short breathing pauses and more than 5 episodes lasting more than 10 seconds per hour. So there's going to be 3 types of this: obstructive, central, and mixed. Obstructive sleep apnea occurs when the structures of the pharynx or the oral cavity block the airflow. So there's an obstruction present. Can also be enlarged tonsils, adenoids, a deviated septum, nasal polyps, and obesity. Obesity is one of the main triggers that's occurring with sleep apnea right now in our country, and the respiratory drive is still intact. So they're still able to breathe on their own. It's just there's an obstruction present. With central apnea, that is thought to involve a defect in the respiratory center in the brain. So that's common in individuals that have had brainstem injuries and muscular dystrophy. But the more common one you're going to be seeing is going to be the obstructive sleep apnea. So risk factors for this are males are more at risk, increasing age, and obesity. So that's going to impact with your larger neck circumference. Use of alcohol can also cause this, and other CNS depressants can be contributing factors. Manifestations, they're kind of easy to spot. So loud snoring is going to be the big one. People that are waking up often, because sometimes the lack of oxygen will wake them up. Excessive daytime sleepiness, if they just can't rouse during the day. They have difficulty falling asleep. Headaches in the morning. I suffer from migraines, and one of the first things they did was they sent me in for a sleep study. Memory issues, cognitive problems, and irritability. So dangers to untreated sleep apnea. So if it's untreated, there's an increased risk of developing hypertension, having a heart attack, stroke, obesity, and diabetes. It will worsen heart failure, cause arrhythmias, and there's an increased risk of work-related and driving accidents. So one of the neurologists that I work with always talks about sleep apnea with stroke. So every patient that he has that comes in that's had a stroke, once they're stabilized, he'll send them for a sleep study. So he believes from research, and he'll talk to you about it in depth. It's Dr. Dong, if you ever run into him. Ask him about it. He will give you a nice little lecture on that. Very smart man, very knowledgeable about sleep apnea and its relationship to stroke. So treatment. Treatment is going to be to fix the cause. However, most of the time, they're just going to give the patient a sleep machine, a CPAP machine. So mild to moderate obstructive sleep apnea may be treated by losing weight, abstaining from alcohol, and improving nasal patency, and avoiding the supine position for sleep. So they're not going to sleep supine. Oral appliances can help keep the mandible and tongue forward, and nasal passages can also be an issue as well. So some people will wear those little bands on their nose to kind of help open the nasal. I can't think of what they're called, but you know what I'm talking about. Kind of like a little elasticy Band-Aid looking thing you put over your nose. So nasal passages can be an issue, but the treatment of choice is going to be the CPAP machine. And CPAP stands for continuous positive airway pressure. And there's a couple different types of machines out there, but this is the one that you'll be tested on. There's also a BiPAP machine, which has 2 pressures, but we won't go into detail on that. So continuous positive airway pressure, CPAP treatment, that's going to use mild air pressure to keep the airway passages open so you no longer stop breathing, or you stop breathing less often and you take shallower breaths. And through the course of the week, I'll upload some videos of this for you to watch. The technology on these has really progressed quite a lot. The one that I have has a modem in it, and it uploads to my doctor and to my phone every day. So now we're going to move more into ventilation disorders. So we're talking about moving air in and out of the lungs and an exchange of CO2 and O2 in the alveoli. Acute bronchitis, that's going to be an inflammation of the bronchi, and this can be either acute or chronic. Some people always have bronchitis. The risk for acute bronchitis is increased by the impaired immune defenses and cigarette smoking and otherwise healthy individuals. So cigarette smoking is one of the causes for this. And bronchitis can follow a viral upper respiratory infection. And chronic bronchitis is usually going to be associated with your COPD patients that we'll be talking about a little bit later. So this can be caused by viruses or bacteria that damage the respiratory mucosa, and a complication of a viral infection or an inhalation of toxic gases and chemicals. And that creates inflammation in the bronchi. So it's not just cigarette smoke, it can be toxic chemicals too. Your manifestations, these patients are going to have a non-productive cough in the beginning that will progress to a productive cough. Paroxysmal cough, that is going to be when it's aggravated by cool, dry, or dusty air, and that's a violent attack, so they just can't stop coughing. Chest pain, they're going to have some chest pain, moderate fever, and malaise. The risk factors for these is really going to be smoking and impaired immune system. And you got to think about your patients that have occupational exposures as well. The chest pain with this is going to be substernal. Treatment for this is going to be based off of symptomology. You want your patients to rest and increase their fluid intake again. They could be having NSAIDs for the pain, and broad spectrum antibiotics like penicillin or erythromycin. That's going to be for the patients that have bacterial bronchitis, and that's about 50% of the cases. Expectorant, they're going to use that during the day to help mobilize that secretions and get them out, and a suppressant at night so they can sleep. The expectorants that they typically give, that I see them giving in the hospital, is going to be the guaifenesin, and the suppressant is going to be the dextromethorphan. They're going to do a chest x-ray, and that's to rule out pneumonia, and you really want to educate these people about smoking. So you want to encourage them to stop smoking, because they're just going to keep getting bronchitis over and over again. And speaking of pneumonia, so in pneumonia, we have an inflammation of the lung parenchyma. So this can be infectious, like bacterial, fungi, or protozoa, or non-infectious. And when I think of that, I commonly think about aspiration, but it can also be inhaling of toxic gases. This is the 8th leading cause of death in the United States and 10% of adult hospital admissions in the U.S. A couple different types of pneumonia going on here. The community acquired is when the client who has not been hospitalized develops an infection in the lungs. This is usually going to be your gram-positive bacteria, so your pneumococcus. That's going to be 66% of community-acquired cases. The nosocomial is going to be any pneumonia contracted after at least 48 to 72 hours of being admitted in the hospital. So if they get the pneumonia while being hospitalized or shortly after, that's going to be considered hospital-acquired or nosocomial. Opportunistic, that's going to be found in immunocompromised adults, and that's caused by organisms that are harmless to people in healthy communities, like the pneumocystis or CMV. So the host defenses must be overwhelmed either by the percentage of organisms or their virulence in order for infection to occur. So think about your immunocompromised patients with that. With pathogens, you can have an aspiration of secretions. So think about your patients with their poor swallow. You want to get speech involved with them to help prevent aspiration pneumonia. Inhaling contaminated air or water and through the bloodstream from infected sources elsewhere in the body. So those are going to be some other places where you can get pathogens. These are spread by droplets or direct contact, and that's usually going to be found in the lower lobes. So when you're auscultating, it's going to be the lower lobes where you're really going to hear or not hear something if their lungs are very diminished. And that's really going to be from a consolidation of lung tissue. So think about everything that's kind of settling down there. Sometimes you won't hear anything abnormal in lung sounds, but sometimes you will. It just kind of depends. Few different types of pneumonia that you're going to see out there. First is going to be the acute. That's going to be your rapid onset pneumonia. These patients are going to have decreased breath sound or fine crackles. In the elderly, you're going to look out for fever, altered mental status, and agitation. With the Legionnaire's disease, that, just a little history on that, was first recognized in the 1970s, and that's when an outbreak occurred at the American Legion Convention. So this is going to be an infectious disease caused by gram-negative aerobic bacteria, and the mortality rate of this is going to be, it's pretty ranging from 5 to 30% during various outbreaks. The most susceptible for this particular type of pneumonia are going to be your smokers, your older adults, people with chronic illnesses, and people with impaired immunity. Primary atypical, a lot of times people refer to this as walking pneumonia. This one's going to be caused by mycoplasma pneumonia, and the presentation and course is significantly different than the other bacterial pneumonias. So this often causes pharyngitis and or bronchitis, so you might see that. It is highly contagious, typically mild with they're systemic symptoms, so they're often referred to, again, as the walking pneumonia. And it's young adults and college students, military recruits. These are going to be your primary infected population. Viral pneumonia, that's going to be your influenza and adenoviruses. That's going to be the most causative agents. CMV is increasing in the immunocompromised clients, so 10% of these pneumonias in adults are going to be viral. This one's going to be typically mild and often affects older adults and those with chronic health conditions. This is where you're gonna find your community epidemic. So like your nursing homes, it's going to spread in nursing homes. Pneumocystic pneumonia, that's opportunistic pneumonia, and that's going to be caused by pneumocystis. That's going to be a parasite. This may develop in clients treated with immunosuppressive therapies like cytotoxic drugs for cancer, and those that have undergone organ donation that take immunosuppressive therapies. They may develop in clients also with genetic or acquired immunodeficiency. Think about also your people with AIDS. That accounts for about 60% of the cases. Respiratory distress can be significant with these, with intercostal retractions as well as cyanosis. And these are severe in those patients due to compromised immune systems. Then aspiration pneumonia. This is going to be an aspiration of gastric contents into the lungs, and that results in a chemical and bacterial pneumonia. So lower pH of gastric contents causes a severe inflammatory response. Complications of this can be abscess, bronchiolitis. So think about your bronchioles there. Gangrene of the pneumonia tissue is another issue, and that's quite severe. Risk factors for developing aspiration pneumonia are going to be emergency surgery. Obstetric procedures also increase that risk. Depressed cough or gag reflex. I think about this often with my patients that have strokes. Impaired swallowing, enteral nutrition, and then silent regurgitation. So prevention, we want to minimize the use of certain medications that cause this, promote anesthetic elimination from the body, and then prevent nausea and gastric distension. I also want you to think about your patients with impaired swallow. You should really be getting speech therapy on board with that to help decrease that. They've got new research says that in addition to different types of diet, like soft diets and mechanical diets, that you can put somebody on what's called a Fraser water protocol to help decrease the incidences of pneumonia. And that's where you can drink plain water 30 minutes before or after a meal, because it's been shown that aspirating water does not cause pneumonia. I gotta love research. So diagnostics, they're going to be doing a chest x-ray, and we see this person has pretty diffuse pneumonia in the right lower lobe. A sputum for gram stain. A lot of times these can be really hard to get. You'll see the order was taken like 4 or 5 days ago, but every single time your patient coughs, they cough into a tissue. Well, you can't collect that. They have to cough directly into the sputum catcher. So they'll also, when they collect these, they will do a culture and sensitivity report to see what that microorganism is susceptible to. CBC, we're really looking at elevated white counts for their to measure how their body is responding to antibiotics and to our other treatments, pulse oximetry, and ABGs. We haven't really talked about ABGs a whole lot. So the PaO2 of less than 75 to 80, that really indicates impaired gas exchange. So measures of pH, CO2, O2, and bicarb levels are what we're looking for with an arterial sample. They can also do a VBG instead of an ABG, and that's looking at the venous blood. It's a little less traumatic on the patient. If you've ever seen an ABG done, they look like they hurt quite a lot. It always worries me when they're doing them and the patient doesn't move, because they are quite painful. So health promotion, we really want to focus on prevention. With this, prevention is going to be the key management strategy, as well as early detection and treatment. So we want to recognize the signs. Think back to aspiration pneumonia. We want to recognize the signs of pneumonia in those patients. So pneumonia, the vaccine, that's made from antigens from about 20 different types of pneumococcus. And this usually imparts about a lifelong immunity, although they want these clients vaccinated for this about every 10 years. It's recommended for clients that are high risk for adverse outcomes, those over the age of 65, people with chronic cardiac or respiratory conditions, diabetics, alcoholics, and other chronic conditions. Anybody that's immunocompromised as well. And really, in addition to this, they want to stress the flu vaccine along with it. Medications to treat pneumonia. We're going to be using antibiotics to treat the infection and bronchodilators here to reduce bronchospasm and improve ventilation. And so is spirometer, that's going to promote deep breathing, coughing, and the clearance of respiratory secretions. Chest physiotherapy, that's going to be your percussion, your vibration, and postural drainage. And that's going to reduce consolidation and prevent atelectasis. And these antibiotics here, just as a side note, they're going to be chosen based on the results of the gram stain and the pattern of lung involvement. So they're going to try to tailor it to the specific needs of that particular organism. And then agents to liquefy mucus, of course. You're going to increase fluids on these patients to help do that. Other treatments, oxygen therapy, I already talked about the increased, I already talked about those, okay. Your B2 antagonist, that's going to be your quick relief, so that takes effect in about 20 minutes. This is going to be a bronchodilator medication that opens the airways up by relaxing the muscles around the airways that may tighten, and that works by causing muscle relaxation and airway dilation. There are two different kinds of beta agonists, and these are grouped according to how long they work. So there's going to be short-acting and long-acting, and beta agonists can be given several ways, but the most common way is going to be inhalation. Also, just to be sure that you note that these can cause some pretty significant tachycardia and tremors, so they can have some shakiness with us. Examples of that's going to be your albuterol, your Proventil, your Ventolin, and these can be given routinely. They're not for fast relief, but they do assist quite a bit with these patients. Anticholinergics, these are going to be what you're going to use to relieve acute symptoms. They take a full hour to begin working. So anticholinergics, they're going to enlarge and dilate the airways in the lungs, and that's going to make breathing easier. So bronchodilator, they may protect the airway from spasms that can suddenly cause the airway to become narrow. So think about your bronchospasms. They may also reduce the amount of mucus produced in the airway. So prescription anticholinergics, the generic name is going to be acetylene, and ipratropium is another one. So Atrovent is going to be your long-acting, that's also called Spiriva. And then prescription anticholinergics and short-term beta-2 agonists, there's going to be a combination of drugs that combine those two. So the generic name for that's going to be albuterol convent, or duonep. So you're going to have those last two that I mentioned are going to be a combination between your anticholinergic with a beta-2 agonist. So they're going to have both of those together. Theophylline, this is going to relax smooth muscle and decreases inflammation. These theophylline medications are the third in a group of bronchodilators that affect the muscles in the airways. So these drugs, however, are also believed to help decrease swelling in your lungs. When the lungs are irritated, the muscle bands around the breathing passages can tighten, making the airways smaller. Theophylline is going to stimulate these muscles so that they relax a little bit and make the airways widen, and that's going to make it easier to breathe. So you should have blood tests done while you're on this medication because there are toxic levels, and you don't want the serum level to get above 20 with this medication, and really they should be avoiding caffeine. So with pneumonia and oxygen therapy, if you think about it, your room air is going to be about 21%. So nasal cannula at a low flow, and when I say low flow, that's going to be those clear cannulas. The green one's going to be for high rates greater than 6 liters. That's going to be about 24 to 45% oxygen. If you're putting them on that, on a nasal cannula, I automatically just add humidification for that because it just tends to dry out the nasal passages. So there's a couple different options for giving oxygen. This is going to be your traditional nasal cannula, and like I said, the green ones are going to be your high flow, so greater than 6 liters. The other options are going to be a simple face mask, which this is a simple face mask, and you're going to see, if you look at this in person, there's going to be holes on either side of it. That's so that they can breathe out their exhaled air. But this is going to be for your people that can't breathe through their nose. So think about nasal congestion, mouth breathers, people that fall asleep and their mouth comes open, those kind of things. This one the face mask, just to go back to that for a minute, that can be for 5 to 8 liters, and it's about 40 to 60% oxygen. This is going to be your non-rebreather, and she looks way too comfortable and not in distress to be wearing that. So these are going to be patients that are in quite a bit of distress. I'm going to put something like this on them right before they end up on a breathing machine, so right before we BiPAP them or ventilate them. So that's going to be up to 100% oxygen right there. And then the Venturi mask, which is going to be 24 to 50%. And again, you really want to make sure that you're humidifying this air because it dries out the mucous membranes, and it can cause a sore throat as well. This is going to be your chest physiotherapy. This is going to reduce lung consolidation and prevent atelectasis. So percussion, they do the percussion by striking or clapping the chest walls with cupped hands. This is done manually. The respiratory therapist will come in and do this. Vibration, that's this machine right here. They'll come in, it's called a CPT, chest physiotherapy device, and they will put that on the patient, and it kind of shakes them around. I call it a shake and bake. So that's going to move secretions into the larger airways for removal. That's performed repeatedly in the hospital with this. It can be done manually, but I think this is really better. They really need to have that machine in place. Postural drainage, that's going to use gravity to move secretions. You're going to position the patient with the segment to be drained superior or above the trachea. And this requires really multiple repositioning, so that you're really having to move the patient around to get this accomplished completely. With education, you're going to provide education on proper nutrition and fluid intake with these patients. You want to help support them through this and help support the symptoms that they're having. Educate them on smoking. If they're smoking, it's likely that they could be following up with a good old case of bronchitis. You want to encourage rest periods. They get short of breath. You want them to have adequate rest to be able to recover for this. And follow your treatment regimen. A lot of these patients, especially after they go home, they do not want to do what the doctor told them to do. So make sure that you're educating them and using teach back on prevention, smoking cessation, and following their treatment plans. Oh, I don't know why it says influenza. There we go. So pneumonia nursing diagnosis for these. You're going to have ineffective airway clearance. A lot of these are going to overlap in this section. So ineffective airway clearance, you're going to listen to lung sounds frequently, watch for cyanosis and respiratory distress, monitor their cough, ABGs if they're ordered, high Fowler's position, that's going to promote lung expansion and movement of secretions. And then promote fluid intake. You want to really push fluids on this to help mobilize and liquefy secretions. So you want to shoot for 2,500 or 3,000 liters a day. Pulmonary hygiene measures, that's going to be your incentive spirometer, your postural drainage, your percussion, and your vibration. Ineffective, I kind of skipped around, didn't I? Ineffective breathing pattern, monitor lung sounds again, respiratory rate, provide rest breaks. These people get really tired. Oxygen, that's going to be if they're PCO2. So if you're taking their pulse ox and it's less than 93%, Unity Point and most hospitals are going to have a policy to put oxygen on them and titrate it to a rate of higher than 93%. So you want to make sure that you're doing that. You're putting oxygen on them if they need it. And teach abdominal breathing patterns to promote lung expansion and respiratory, teach relaxation techniques. Use your incentive spirometer here again as well. Activity intolerance, so assist with ADLs if needed, but you really want to encourage them to do as much as they possibly can. You don't want them to lose function. Schedule activities with rest periods, use assisted devices, range of motion, and support. So, pleurisy, pleuritis. This is going to be an inflammation of the pleura. The signs and symptoms of this are going to be shortness of breath, fever, and rapid shallow breathing. And on the next slide, I'm not going to play it for you because the audio won't play correctly. I really want you to listen to these because they sound quite different. So when I load the PowerPoint up, I'll make sure to load one without the voiceover. That way you can click on those links. And the sound, this has really resulted from an inflamed layer of the pleura. They're going to rub against each other every time the lungs expand, and then you're going to hear it when you auscultate. They can also have some pretty severe sharp pain with this, with inhalation, and that's called pleuritic chest pain. So when you're doing your assessment on this patient with the pleurisy and they have that pleuritic chest pain, one of the questions I would ask them if they say they're having chest pain is, where exactly does it hurt on your chest? And they're going to tell you it's going to be like the whole right side or the whole left side or both sides, and it hurts when they breathe. That's why it's important to do a full cold spa. A pneumothorax, that's when you're going to have an accumulation of air in the pleural space. This can be caused from a couple different things. So there's a spontaneous pneumo. Sometimes it's caused by trauma, lung disease, or latrogenic. That's going to be caused by a thoracentesis. And if you don't know what a thoracentesis is, that's when they're going to be draining the fluid. And they use a needle to do this, and they will enter through the side of the patient, sometimes through the back, and they will drain excess fluid. Sometimes the lung does get punctured with that. So with a collapsed lung, it's when the pleural is either breached, air escapes from the pleural space, and that equalizes pressure. Lung expansion from here is really going to be impaired, and the natural recoil tendency of the lung causes it to collapse. And it can be a partial, like this case looks like a partial collapse, or a total. And that depends on the size and how rapid the air accumulates in there. So if it's spontaneous, this means it develops when an air-filled bleb or a blister on the lung surface ruptures. So the rupture allows the air from the airways to enter the pleural space, and air accumulates until the pressures are equalized. So that's not very common, but it really looks kind of like a little tiny blister off to the side. And the only time I've ever heard of a patient having an issue like that is when they were on an airplane. It was like pressure related. Here's an example of inserting a chest tube. So they're going to go in through the intercostal space right there. It's pretty violent. They have to push quite hard to do that. And then there's a picture of the chest tube itself. It used to be like old school. They used water bottles, and now they use this nice little device. So this is a sealed chest tube with, they can hook it up to suction as well. And you're really monitoring these quite often. You'll go over this in more detail in complex, so I'm not going to burden you too much with it. Education for these patients. If they smoke, you want them to stop smoking. If it's a safety issue, like think about what I said with trauma, you want to educate them on safe behaviors, preventing and reducing falls and injury. So really with these patients, depending on what caused the issue, sometimes it's a car accident, sometimes they were out ATVing, it just depends on what the exact issue is. Educate them on prevention. Oh, look, I did it again. That means it's going to be on all of them. So nursing diagnosis for these is going to be impaired gas exchange again, and a risk for injury. And a lot of these interventions that I mentioned earlier are going to overlap. So now we're going to talk about nursing care of patients with gas exchange disorders. And asthma is going to be our first one. So this is chronic inflammatory disorder of the airways and widespread airflow obstruction. So this can reverse spontaneously or with treatment. So that's one of the possibilities. So sometimes by itself, but most of the time you're going to need some treatment. It's more common in children. Women have a higher mortality rate associated with this, and the mortality rate is about 3 times higher in the African American population. This is going to be characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. And a lot of times with these patients, if they are no longer able to speak, if they're just nodding at you, they are really in distress because they cannot move enough air to speak to you. Triggers for this is something that can be triggered, so we want to avoid those triggers. Allergens, these could be many. They can be animals, it can be environmental. There's a lot of different triggers. Respiratory tract infections, so these patients really need to make sure that they're vaccinated for influenza and stay away from sick people. It can be exercise-induced, inhaled irritants, and NSAIDs, and beta blockers, aspirin. So those are some of the examples that all of their physicians, if they're being treated by a lot of physicians, need to be aware that they have asthma. And it can be stress-induced. So during an asthma attack, bronchoconstriction happens, edema and inflammation, and mucus secretion starts to narrow the airway. Airway resistance increases, and that really limits airflow and increasing the work of breathing. So think about what I said with your patients that aren't able to speak anymore. Your manifestations, they're going to have some tightness, cough, shortness of breath, wheezing, and during an attack, they're going to have some tachypnea, some tachycardia, prolonged expiration, and then during severe episodes, intercostal retractions, use of accessory muscles, and anxiety. Anytime I see a patient that has sudden anxiety that wasn't present anymore, I automatically think that there's a gas exchange problem. This patient's not getting enough air and it's making them anxious. Think about if you can't breathe, you're going to feel very anxious. Some diagnostics for this, they're going to perform a PFT. So that's a pulmonary function test, and that's used to evaluate the degree of airway obstruction. This is done before and after the use of aerosol bronchodilators, and that helps determine the reversibility of the airway obstruction. ABGs, that is going to be used to evaluate oxygenation during an acute TAC, and remember, those are quite painful to the patient because they're going straight down into the arterial. So just keep that in mind to support them. A challenge test, that's a bronchial provocation test that uses an inhaled substance such as methacholine or a histamine with a PFT, so it's done congruently to determine the diagnosis of asthma by detecting airway hypersensitivity. They could also be doing a peak expiratory flow rate, a PEFR. That evaluates airway obstruction by testing how fast a person can exhale or breathe out. That evaluates the severity of an asthma attack and the effectiveness of treatment measures. And it has a color coding system with this. These patients can see where they're sitting at with their asthma. So green's going to be 80-90%. That's going to be the best. Yellow, 50 to 80. That means these patients are needing treatment imminently, and red is 50% or less. They really need immediate treatment with a bronchodilator and medication, and possibly transfer to a hospital. And a scratch test, that's going to be testing for allergies, so they would go to an allergist to get this done, and they would determine what's causing these, what are their triggers. Treatment, they're going to avoid any allergens based off that scratch test. Bronchodilators, they're short-acting, they're albuterol. Anticholinergics, your ipratropium bromide to help treat that. Theophylline, corticosteroids, think about your precautions with any corticosteroids, and leukotriene modifiers. So this is going to be an example of an MDI, a metered dose inhaler, and that's a device that helps deliver a specific amount of medication into the lungs. So that way the patient doesn't have to measure it. This is commonly used to treat asthma, chronic obstructive pulmonary disease, and other respiratory issues as well. Sometimes I've seen it done with bronchitis. Each inhaler consists of a pressurized container of medication as well as a mouthpiece, and pushing down on this inhaler releases a mist of medication that you breathe into your lungs. That way you always are getting the right amount of medication, and it's important to use these correctly. Sometimes they will have a spacer device with this too. And here's just a nice little graphic on how to use this. So usually you're going to want to have the patient hold it at 1.5 inches or 2 in front of the mouth. They want to shake the medication before they do that. Sorry, I missed that step. And breathe in for 3 to 5 seconds. So usually what I'll have them do is I'll have them exhale all their air and then take the medication. And then they always want to rinse out their mouth after this. That's a very important step. A lot of people miss that, and then the patient ends up getting thrush from their inhaler. So they want to rinse out that medication afterwards. And as we get later in the week and closer to the test, I'll post a video on how to use these, so it'll be a little bit more clear to you. Dry powder inhalers. These are going to be devices that delivers a medication into the lungs in the form of a dry powder. And this is going to be an alternative to aerosol-based inhalers. These rely on the force of the patient's inhalation to deliver the powder from the device, and they subsequently break up the powder into an aerosol. So really, they have to be able to inhale forcefully. So they're going to breathe in rapidly and deeply through their mouth over 2 to 3 seconds to activate the flow of the medication, and they need to hold their breath for 10 seconds afterwards. Exhale through pursed lips, and then rinse mouth or brush their teeth again afterwards. If you haven't guessed it, a lot of what you do as a nurse is education. So this is going to be a nebulizer, and they also call this a breathing treatment, and this medication is changed into a liquid prior to inhalation. So they're going to put the medication in a cup and then breathe it in. So there's different types of attachments with this. Some of them will have a face shield. So don't be surprised if they look different. We do not allow these to be used in the hospital. Respiratory is going to come and deliver all of their naps. They are allowed to use metered dose inhalers and the powdered inhalers, but this one is something that respiratory ends up taking over. And I should say it depends on the hospital, because some hospitals, the nurses do it. So you can see here the medication is being instilled in the neb device and prepared. And again, respiratory is going to handle this at UPH. So when you start getting into your clinicals, when you're passing medications, you will not be passing these kind of meds. Health promotion, you want to discourage these patients from smoking. Think about who else lives in their house with them too. They could be smoking, so you want to educate on that, because secondhand smoke is just as bad for these patients. Prevent illness. Early exposure to infectious diseases can really cause exacerbations and asthma. Sorry, my words are getting hard. And then limit the use of antibiotics in children when they're young, and stay away from triggers. That's going to be a big one. So additional evidence suggests that early exposure to certain infectious diseases and to other children, and limited the use of antibiotics helps reduce the risk of asthma. So just something to keep in mind. I bet you I have this one labeled wrong too. Oh no, I don't. It's right. Okay, so same thing that you've been seeing. Ineffective airway clearance. Think back to the other interventions I said. They're going to apply here too. Ineffective breathing pattern. Anxiety. Again, these patients, they can't breathe, they're anxious. An ineffective therapeutic regimen. So if they keep having attack after attacks, we need to look at what they're doing to treat themselves at home, because this is really something that they need to be treating probably on a daily basis, depending on how severe it is. COPD, or chronic obstructive pulmonary disease. So this is a chronic airflow obstruction due to chronic bronchitis and or emphysema. So they could really have both. This is going to affect middle-aged and older adults, and cigarette smoking is going to be your primary cause. Other contributing factors are air pollution, occupational exposure to noxious dust and gases, airway infections, and familial or genetic factors. So it can run in families. So COPD is going to be characterized by a slowly progressing obstruction of the airways. The disease is one of periodic exacerbations. So it's often going to be related to respiratory infections with increased symptoms of dyspnea and sputum production. The airways and lung parenchyma do not return to normal after an exacerbation. So once this flares up, it does not go back to normal. They demonstrate progressive destructive changes. So what does that mean every time they have a COPD exacerbations? Lungs, that means your lungs are irreversibly damaged, so they will never be normal after that. Periodic exacerbations do increase the shortness of breath and sputum production, and then after an exacerbation, airways demonstrate progressive destructive changes rather than returning to normal. So they will not be normal about this. This is why we want to really prevent these patients from getting illnesses. It's just going to make their disease worse. COPD, PD, and chronic bronchitis is a disorder of excessive bronchial mucus secretion. So the excessive secretion is creating really an airway obstruction. They're going to have a productive cough. This is going to last for quite a long time. And they could have 3 or 4 months and 2 consecutive years. Some of them never stop coughing. The major contributing factor, again, here is going to be smoking. So you want to educate these patients on quitting. And inhaled irritants, again, are going to be a big one. Chronic bronchitis is going to be the recurrent infectious one, and there's going to be an imbalance between their ventilation and perfusion. So hypoxemia, that's going to be decreased partial pressure of oxygen in the blood. They're going to have O2 saturations of less than 90% in this case. And hypercapnia, that's going to be too much, so they're going to be retaining CO2 in the blood. So COPD patients, they retain a lot of CO2. So they're going to suffer from hypoxemia, hypercapnia, and pulmonary hypertension, and that can really lead to some heart failure with these patients. With emphysema, cigarette smoking is a strong contributing causative factor. The lung tissue here is destroyed, leading to inflammation. What's happening, here in emphysema is you have alveolar wall destruction, and that causes the alveoli and air spaces to enlarge with loss of corresponding portions of the pulmonary capillary bed. So they get quite big. They lose a lot of elasticity there too. As a result, the surface area of the capillary diffusion is reduced, and this is really going to affect their air exchange. If you look at this, COPD is going to be progressive and non-reversible process of airway narrowing and loss of supporting tissue. So separate processes are occurring. Chronic bronchitis with persistent airway edema, excessive mucus, and impaired airway clearance. emphysema with loss of alveoli walls, capillary bed, and airway support tissue, resulting in airway collapse and reductions in gas exchange, and small airways disease with bronchoconstriction and constriction in the bronchioles. So it's really quite progressive with these patients. And here you can see a comparison between the two. So the patho for chronic bronchitis versus emphysema. With chronic bronchitis, we have persistent airway edema, excessive mucus production, and impaired airway clearance. With the emphysema, we have a loss of interstitial membranes and airway support tissue, which results in airway collapse and a loss of alveoli surface for gas exchange. And again, comparing the manifestations of the two, you can see quite a few differences here. So with chronic bronchitis, we've got the productive cough, copious amounts of thick sputum, potentially cyanosis, right-sided heart failure, and adventitious lung sounds. They're going to have some rhonchi and possible wheezes. With emphysema, dyspnea initially is going to be a sign of that. Cough is minimal or absent. They're going to have a barrel chest. These patients are going to be thin and have tachypnea. They're going to use accessory muscles, and they're going to assume a tripod position for breathing, and I'll show you what that means. And their lung sounds are going to be diminished. They're going to be decreased. This is going to be the tripod, so they really lean forward. A lot of times I'll see them braced on the bedside table, and that's just the way that that's the most comfortable position for them to get that CO2 out. And they'll do a lot of pursed lip breathing too. And this is what we're talking about with a barrel chest. So this is the normal chest, and this is the barrel chest. Their body's trying to compensate. So the barrel chest, that's going to be due to air trapping and hyperventilation, and it increases the AP chest diameter. So again, they're trying to compensate. In the tripod position, they sit up, they lean forward, they rest their hands on their knees or on a table. When the patient finally seeks care for their symptoms, they have been present for as long as 10 years. So they don't seek help right away. And they're usually mild or minor symptoms initially, such as activity intolerance, and they may place blame on age, so they might think it's just normal for them to feel that way. And the cough usually occurs in the morning, and it's attributed to a smoker's cough, so they'll kind of blame it on that. Some different diagnostics for this. They're going to do a PFT. I'm trying to think if I already talked about a PFT and what it was for asthma. Okay, I'll talk about it again. Pulmonary function test. This is going to be a group of tests that measure how well the lungs take in and release air, and how well they move gases such as oxygen from the atmosphere into circulation. So how this is performed with these patients in a spirometry test, they breathe into a mouthpiece that is connected to an instrument called a spirometer, and the spirometer records the amount of rate of air that they breathe in and out over a period of time. For some of the test measurements, they breathe in and out normally, and other tests require forced inhalation or exhalation after a deep breath, so it just kind of depends. Ventilation perfusion, sometimes these are also called a VQ scan or a VP scan. This is going to be a pulmonary ventilation perfusion scan, and that's going to be paired with a nuclear scan. And these tests use inhaled and injected radioactive material, so they're going to use radioisotopes to measure breathing, ventilation, and circulation in all the lungs. So when you're looking at this, you can see they can see the air moving in and out, as well as the circulation around the lungs. So it's really a good test to help rule out PEs too, so pulmonary embolisms. ABGs, again, these are going to be drawn from the artery, and that's often the brachial or the radial artery, and that's going to be used to evaluate gas exchange, measure pH, carbon dioxide, bicarb, and O2 saturations. And oxygen levels are really going to be typically low in patients with chronic obstructive pulmonary disease, sorry about that. They'll also potentially pulse oximeter. Do you know what that is? It's when you put that little meter on the finger and it tells you what they're reading at the moment. And a CBC with differential. So that's going to show increased RBCs and hematocrit. And think about why. Why are they going to have more red blood cells? Because really their body is compensating to make up for a reduction in oxygen. So the body is trying to compensate by increasing the oxygen capacity in the blood. Chest x-ray, that's going to show flattening of the diaphragm. And think about why with that one too. That really is caused by hyperinflation. So the lungs are taking up more space. Skipped one. So medications, yearly vaccines, again with these patients, we want to reduce the risk of respiratory infection. It could potentially cause an exacerbation. Antibiotics, they would, if an infection is present, they would use broad spectrum. The study shows that patients with purulent sputum and increased dyspnea benefit from antibiotics even if there's no signs of infection. So make sure you're paying attention to research with that. Oral bronchodilators, those can be associated with much higher rates of adverse effects. So be careful with the orals. We prefer the inhaled ones. And then corticosteroids. Those oral steroids such as prednisone are started initially, and the common side effects of those are going to be sore throat, hoarseness, oropharyngeal, and laryngeal. You're going to look out for thrush. So oropharyngeal and laryngeal candida. So thrush, yeast infection. Administer antifungal medications and gargles as ordered, and oral has a higher risk of having Cushing's effects. So monitor your patients with their doses. Oxygen is really a hot topic with these patients with COPD. So you use it with caution, and I'll go over that down here. So that's weird. Long-term use is that's reserved for severe and progressive hypoxemia. This improves exercise tolerance, mental functioning, and quality of life. And it may reduce the rate of hospitalization in these patients. So they're going to come into the hospital less, and that's always a good thing, so it's going to reduce the risk for infection. Increases length of survival, and acute exacerbations, they may really require it. So just to be cautious with this, COPD clients have a chronically elevated CO2 level in their blood. So administering oxygen really increases their PaCO2 levels, and this can lead to somnolence and respiratory failure. So you need to be careful with this. A lot of times, nurses, they really want that 93% saturation rate, but that guy with COPD in room 12, he does okay at 90%. Leave them at 90%. If it makes you feel better, get a doctor's order saying it's okay to leave them there because they've got COPD and you don't want to shut off their breathing by giving them too much oxygen. Smoking cessation, that's a huge one. I see it all the time. I do work at the Goodwill Home for Vets, and it's a homeless shelter for veterans, and there's several clients there with COPD on oxygen, and they will go outside and smoke. Drives me crazy. No amount of education is going to help with that, but I keep trying. Isolate them. If somebody's sick in the family, make sure that they're not exposed to that. That's what I mean by isolation. So you want to stay indoors too during high allergy seasons because those contaminants can really exacerbate that issue. Avoid cough suppressants and sedatives. We really don't want to shut off their respiratory response, and we want to make sure that they can cough up secretions when they can. Educate them on the pursed lip breathing. this is where I would show you how to do it, but we're not in person, so I can't do that. I'll make sure to post a link for you. Increase fluid intake. These patients, they need to thin those secretions, so they need to increase their fluid intake to do that. Effective coughing with huffing at the end, percussion and postural drainage, and treat infections early. Your nursing diagnosis, so ineffective airway clearance here. We're going to assess respiratory status, rate, pattern, cough, secretions. Make sure you're charting your secretions. What color are they? Are they thick? That kind of thing. Are they able to cough them up independently? Make sure you're charting your breath sounds. Monitor oxygen saturations, ABGs, daily weights, because dehydration can really thicken secretions, and fluid overload can also compromise these patients. Encourage fluid to thin secretions. Fowler's or high Fowler's position to promote ventilation. These are the patients, when you lay them down flat to boost them up in the bed, they're saying, put me up, put me up, put me up. They cannot breathe flat. Cough and deep breathe every 2 hours. Really, they should be doing it more often than that. Get them an incentive spirometer if they can tolerate it, or a flutter valve. Sometimes COPDers can't handle the IS, the incentive spirometer, but they can handle a flutter valve. And that's the one that looks like a pickle. Suctioning if they need it, expectorants and bronchodilators to clear airways, and supplemental oxygen to maintain adequate blood tissue oxygenation. The other ones are going to be impaired nutrition, less than body requirements. These patients, they choose to breathe over eating, so a lot of times they cannot sit down and eat a whole meal. They're going to eat small meals, encourage them to eat more often, and encourage the proper nutrition with them. Compromised coping, a lot of times they either are in denial, and they keep smoking, or they think it's all their fault because of the smoking. Decisional conflict making, that's because of the smoking again, and impaired gas exchange. Atelectasis, I promise you we're almost done. So atelectasis is not really a disease, but it's a condition, and it's associated with many respiratory disorders, and it can be a partial or total collapse of the lung here, and it can be acute or chronic. The causes of this can be obstruction of the bronchus, a pneumothorax, pleural effusion, a tumor, loss of pulmonary surfactant, or even an inability to maintain open alveoli. And you can see this on a chest x-ray. These patients are going to have decreased breath sounds, and that may be the only sign that you notice of it. So you're really going to make sure that they use their incentive spirometer. Manifestations, again, breath sounds may be diminished or absent. They may have some tachycardia from this and some tachypnea with dyspnea. You may see some cyanosis, but usually in the beginning what I see is fever. So think about your post-op patients. They've had surgery, they've got a little bit of a fever, maybe it's mild, their lung sounds are diminished. Before I even call the doctor, I get that patient to use the incentive spirometer, and usually that clears up the fever. And what I'll do is I'll call the physician and say, hey, I'm calling about so-and-so in room 12. You know, they just had that surgery, they've got a little bit of a fever, their lungs are diminished, I have them using an incentive spirometer. Is there anything else you want me to do? And they're like, nope, good job, nurse, you got it. So just be aware that fever can be an early manifestation of atelectasis, and using that incentive spirometer is a great nursing intervention for a lot of things. So your high-risk clients for this are going to be your COPDers, your smokers undergoing surgery, prolonged bed rest, and anybody with mechanical ventilation. So think about your patients that are undergoing extensive surgery. They're really high risk for that. So that's going to be your primary focus of care, is going to be prevention. You want to maintain that airway and really push those patients to use that incentive spirometer. It really does help, and deep breathe and cough. Treatment is going to be focused on identifying the underlying cause, vigorous coughing, chest PT, bronchoscopies or antibiotic therapy, but really do the incentive spirometer. Coughing and deep breathing can help if they have an obstruction from mucus plug, just as an FYI. Bronchoscopy only if they really need to remove an obstruction. I don't see that happen very often. And antibiotic if it's an infection. Nursing care, you're really going to be focusing on airway clearance with postural drainage, turning that patient often, early ambulation. This is never going away. Deep breathing and coughing, incentive spirometer, and increasing your fluid intake. And anytime I say increase your fluid intake, just use caution in patients with heart failure and renal failure, which will be the next section. And then any questions at all, just make sure to post them on a discussion board post, because we like to share knowledge with each other. You guys are doing a fantastic job. Hang in there. We are getting there. We're getting there. Good job.